Hello. Hello.
You look very nice, Calandra.
So do you.
Thank you.
I like your earrings.
Thank you. Let me put on my, I guess I don't need a background. It's pretty plain here.
Are we admitting the panelists yet or not
Yeah,
yet?
we can admit.
And I downloaded the latest version of the presentation from SharePoint. Is that the one we're using?
Yeah, I added SharePoint. Is there the reentry slides and the housing slides on there? Just to make sure they loaded. The reentry slides are blue and the housing slides have a lot of good information on them. Oh, Mr. Ron.
How are you?
Doing well.
Okay, good deal.
All right, can you hear us okay?
Sure, I was just wanting to make sure I was good and connected and everything. Okay.
You are like phasing in and out just a little bit. I don't know if that was just for me.
I'll log out and come back in, try it again.
Okay.
These are the slides, correct, Allison?
Yeah, those are the reentry slides, and then the housing slides are at the end. Can you just double check to make sure they loaded? Yep. Okay. Yep, those are the housing slides.
Okay.
Hi, Dr. Wiggum.
Hi, how are you?
Doing well. We're just getting ourselves set up here. We can hear you. Can you hear us?
Okay.
And just to double check, Allison, I am pinning the speakers
Yes.
as they are presenting their slides, correct?
Yes.
Sure.
Can I jump away for a second?
Yes. Yep.
Okay.
We just
Okay.
want to make sure everyone could connect. So you can come back at 6. Let's start
Right back.
admitting. Yep. Let's start. Well, panelists, we can admit anytime. Let's start admitting participants at 58 and put the icebreaker up at 58. And I am also monitoring email because sometimes people can't get in. And they email me. Sylvette is monitoring the PGHAC email. You guys hear my dog in the background?
No.
Okay. I'll just leave him where he is. It's thunderstorming, so he gets really anxious.
Yeah, it's storming here too.
And starts panting a lot when it storms. So he's here panting. And my daughter is gonna come in about 3/4 of the way through the meeting and start watching cartoons because it's the baby's bedtime and we need to put her somewhere. Pretty sure my headset won't pick up the volume.
It's all good. It's real life. Hey, Cheryl.
Hi, Guy. How are you?
I'm pretty good. It's been a busy, busy day.
Yes, it has been.
I hear a dog pitter pattering around behind me. I don't see him though.
And I'll be right back. I'm just gonna step away for a moment.
Did we hear back from Ashley? Is she good to go?
Yes.
Okay. Ronnie, you're on. I see I see your name. I don't see your face.
Yes, sir. We are here. How are you today, this
I
evening?
thought maybe you were eating some last minute dinner like I was trying to do.
I am.
I made dinner early so that I could wolf it down and be here. Because I have to eat on time. If I don't eat on time, I'm not happy.
Right. I understand.
I'm eating last minute dinner. I'm trying to finish it in the next six minutes before we let folks in.
Oy.
Thank you all. If you all need to go, take care of things, get some water before 6, go ahead. It sounds like everybody is connected and our sound is working.
Okay, I didn't see Ed come on. And I suspect that he might be trying to link through the other Zoom link for, what do you think, the attendees?
It's just one link for everybody.
Okay,
You guys just get let in the room
earlier, okay.
early.
Health and all policies.
Okay, so you said we can break until about 5 of? Okay,
I can break till 6. Just wanted to make
So-
sure we ironed anything out.
okay, cool. I'll be back.
Mr. Ron, can we get another sound check from you? I know it was a little bit spotty earlier.
Yes, I believe it's a little better now, hopefully.
I think so.
Could you hear me that time? Is that fine? How's everybody doing tonight or this evening?
Wonderful. Did you do okay, Ron, with, did you get the information on how to get cleared for background at the jail?
I did get it, and when I went through the process, I couldn't. There's a step that I couldn't that I was not able to locate. So I reached out to, I think it was Miss Anderson.
Okay.
Yeah. We'll make sure to work through it.
Okay, we got 6 minutes. I'm gonna go wash my glasses off.
See, I just messaged everyone in the waiting room, just let them know we're gonna be letting them in momentarily. Hi, Donna.
Hey, how are you?
Good.
I realized
Um,
I didn't send you all my update with the vaccination slides. Do you want me to send that to you now, or do you want me to just like jump in and share my screen when the time comes? I just
You
have
can
like
sh-
a couple of slides.
You can share screen. Orlando, can you just make sure Donna's co-hosted? Or whoever's got the host. All right.
Cool.
Yeah. So you know, relax about 5 minutes. So I wanted to make sure we got any kinks ironed out. I'm going to continue to shove food in my mouth for the next approximately 3 minutes.
Let me ask you a question. Can you guys still see me? Okay,
Yep.
because I'm working on one computer and I'm gonna pull the, I wanted to pull the our agenda for tonight up.
Good evening, Renee and Paul.
Good evening.
Get a quick sound check from Renee. Paul, everything coming through on the audio okay for you? Uh-oh. Well. Renee, Paul, can you hear us? Uh-oh. Well, this is why we're here early.
Don't you miss the good old days when we were all here together eating eating sardies?
I do miss
Yes.
sardines.
Absolutely.
Did
And
Renee,
having brownies for dessert?
Mhm.
did Renee drop off?
Rejoining.
Okay.
Did I hear someone say they're sending brownies for dessert?
No, we used to have
Everybody?
these, no, we
I
just
miss-
used to have these wonderful meetings where we had food. Delicious
Ah.
food.
Okay. It won't be long now.
Okay. Glenda, let's fill up the icebreaker. And Paul, can you hear us? Anyone mute?
Can you hear me now?
Yes. Perfect.
Okay.
And we see you too.
Oh.
We can go ahead and admit participants.
Listen,
Good evening. Welcome to the quarterly meeting of the Prince George's Healthcare Action Coalition. As we wait for folks to sign on, we do have a short icebreaker question for you. We want to know, what is the one post-pandemic change you would like to see happen in Prince George's County? And you can join the poll by clicking on the link that will be posted in the chat, or you can also answer the poll question by text, and there's the number to text your response to there. So think about, what is one post-pandemic change you would like to see happen in Prince George's County?
so I've never done the text thing. So I'm texting to 22333. Right?
Yes, 22333. Hi, welcome to the quarterly meeting of the Prince George's Healthcare Action Coalition. While we wait for folks to sign on, we have a short icebreaker. What is the one post-pandemic change you would like to see happen in Prince George's County? So you can put your response, and they will be shared by clicking on the link that we're going to repost in the chat for those who just joined, or you can also text Calandra Witt 417 to the number 22333. So text to join, and then you can text in your message. So the one post-pandemic change, as we're turning the corner, that you would like to see happen in Prince George's County. Go ahead, click on the link in the chat or join via text. We see your responses coming in. As we wait for folks to sign on, we want to hear the one post-pandemic change you would like to see happen in Prince George's County. And our answers are scrolling through here. there a way we can see all of them at once? All right, so we definitely see more investment in infrastructure. Looks like our poll was a little bit stuck, but we thank everyone for your responses. We'll get those up on the screen in just a moment. And if you're just joining us, we're going to repost the link in the chat. What is the one post-pandemic change you would like to see happen in Prince George's County? I think we will actually come back to it at the end because it looks like it's a little bit frozen right now. But with that, we will go ahead and start our quarterly meeting. And so I would like to welcome our health officer, Dr. Carter, to bring us all together. Dr. Carter, take it away. Dr. Carter may have gotten called away to something. Paul, for the last time, do you want to take us away here?
No, it's my pleasure and honor to do so as I end my term. But Allison, thank you, and welcome to everybody as we get this meeting started. I am very proud of the work that everybody involved in healthcare in Prince George's County has done for this last year plus, dealing with the most challenging healthcare crisis that we've ever seen, certainly in our lifetime. And I am humbled to be a part of this coalition, and I'm proud of the work that the people that dedicated to this coalition have done. And all the folks in the healthcare field in Prince George's County have done to really supersede what I think anybody ever would have expected, or that the system in Prince George's County to do. And I say that with all humility, because there was such a mystery about an uncertainty about what we were dealing with, but it always goes to show that when you have a group of dedicated people focused on what needs to truly be done, and that they actually put their resources together and set their differences aside for the greater good. And that's what this was all about. It was just a very great effort on the part of everybody. And I was proud to be a small part of it, but I commend the work of the coalition before, during, and I'm looking forward to what the coalition will be doing after, to assure that healthcare services for the residents of Prince George's County continue to be at the top of the pyramid of what needs to be done and what folks in Prince George's County truly deserve. So thank you for that. And Allison, at that point, I'll turn it back over to you.
Thanks. Dr. Carter, any words from you?
Thank you, Allison, and thank you, Paula. You know how much we appreciated your service, and you're a great partner and co-chair for this coalition, and the progress that we've made with our coalition is under your leadership, and with Allison and all of the folks who have been with us for a while. It's just remarkable, and so we're really grateful for the ongoing efforts here that we have here with our coalition, and we look for the continued work. And I'm excited about the coming year. I think this next year is going to be a really, really bright for us. We have a lot of opportunity, as Paul said, we've sort of gotten through this pandemic. We feel good about the fact that we were able to still make great strides in the community, and our community outreach efforts have been, I think, really tremendous. And I think just like any organization that comes together, our organization is starting to gel, starting to feel strong and connected. And that takes a while. It takes a lot of effort and energy from the leadership, but also from the members. And our coalition has done exactly that. So I am very proud of our coalition. I think it's going to make a tremendous difference in the years to come. It's made a tremendous difference now. And basically what you all are all activated to be are our chief health strategists for the community. This is how our community transforms. It transforms with grassroots efforts, with partnerships, because that's the way public health works. And we've got good public health people working in that direction. So I'd just like to thank you all for coming. I'm not going to talk a long time because Allison has given me the eye, but I really do appreciate you. And I appreciate the work that's been done. So with that, I'm going to hand it back over to Allison.
Thank you. And we will have Donna Perkins, the manager of the Office Assessment and Planning, and our chief epidemiologist in the county, give a brief community COVID and vaccination update. We're nearing the end, but we're not quite there yet.
Hi, thank you so much. Great to see so many familiar faces after a hot minute. So I will not take very long either, because I also don't want to get the eye from Allison, but I was asked to just give you all a very, very brief update tonight about where we are with our vaccination efforts in the county. So hopefully everybody can see. Let me just make this sorry, I should have put it into presentation mode. Let me do that real quick. And hopefully everybody can you see okay? All right. So the first thing I wanted to look at was just really we peaked back in mid-April with the number of vaccinations being provided to residents. You can see there the week of 4/11 to 4/17, and we've definitely seen a decline since then of the number of vaccinations provided to our residents. And this is specific to vaccinations provided in Maryland. So I'm only looking at Maryland vaccinations for this particular slide. However, even with that, last week we still saw about 9,000 residents receive a first or a single dose. So we're still seeing folks interested in being vaccinated, but the faucet is slowing down, as you can see. And as you can see, last week we topped 20,000 vaccinations in total, but that is definitely on the decline. When we're looking at, and also, oops, sorry, let me go back 1 second. The key thing though, is when we're looking at this, I also want to mention, where are we as far as the proportion of our residents covered? And right now, when you're looking at 18 and over, we've got about 61% of our residents who have received at least one dose of vaccine. If you're looking at that 12 and older range, of course, you're adding in a younger population. So that's about at 58.4% as of today. So we're right around that 60% mark for both groups, and even a little over if you're looking at adults in the county. And you can really see why here. We've got over 80% of our seniors ages 65 to 84 have at least one vaccination. We're in the 70% for, the kind of those bookends on either end, the 85 plus and the 60 to 64, and over 60% now for our 40 to 59-year-olds. Younger population, still working on those folks. And another question that we get asked often is, how are we doing if we break it down by race and ethnicity? It's a bit tricky because as you can see, we've got a lot of folks that are labeled as unknown or other. So we know that there's some missing information there. But for the folks that did identify by a particular race or ethnicity, we're looking at 55% or higher of residents ages 12 and older for our white and Asian residents have received at least one dose. And we're right at 50% for our African-American Black residents and at about 47% for our Latino residents. So just a very, very brief snapshot of what's happening in the county. And you're welcome to visit our county website, which also details this information down to a zip code level, which folks often are interested in as well. Thank you.
Thank you. We're going to look to the future. Donna just gave us our COVID update, but we had an icebreaker at the beginning and it kind of got frozen. And so our icebreaker question was, what is one post-pandemic change you would like to see happen in Prince George's County? So here are some of your responses. More coordination, more community engagement. We have had a lot of partners come to the table who wouldn't maybe normally be with us. So we want to definitely maintain those partnerships. More investments. I see a theme on collaboration. More investments. So let's just keep those in mind as we near the end and turn the corner. We don't want to let go of those partnerships that we've made during this very difficult time. So with that, we are going to move on to our next agenda item, which is leadership recognitions for our coalition. And I'll let Dr. Carter speak.
Well, this is an important time for us. This is when we want to recognize the folks who have helped lead us through to this point and who we want to recognize. I think, Allison, I don't know we want to start, but I think I definitely, we want to have great praise for Paul, who has worked with us throughout this whole time. He's lifted me up. Grinaldo, and I'm not going to go into all of the times that we, like from the time we first met until now, but he has been a great leader and a great friend in this community, a strong advocate. And I really want to have him active with us throughout our whole, into our future. But Paul has been a strong advocate for us. He's worked with us very closely. And I mean, as him going away as the co-chair leaves a little bit of a deficit in my heart, but at the same time, we have a new co-chair who can step right in, and I'm looking forward to that too. So, Allison, do you want me to start there?
Yes, we have a couple volunteer and staff recognitions, but I just wanted to, Paul, we would have liked to present this to you in person, but it is a glass mantelpiece. It says, Prince George's Healthcare Action Coalition honors Paul Grinaldo in recognition and appreciation of your outstanding vision, dedication, and service to Prince George's County. So this is the piece. This is our awkward presentation ceremony here. And we will get this mailed to you.
Yeah,
it's very, very kind. Thank you so much. I'm humbled.
Really appreciate it. I wish we could shake hands and take pictures, but we can't.
And then we have.
Go ahead, Allison.
We have some staff and volunteer recognitions.
Yes.
So Adeline Dormaville, she was our research assistant for HEAL. She worked with us for almost 2 years. So we just wanted to present this virtual certificate of appreciation to her, and we will get this sent out to her.
Yes.
And Sydney, are you on the line?
Yep, I'm here.
Yes, Sydney has been our healthy eating champion since we started the HEAL work group about 4 years ago. So thank you, Sydney. And she is still going to be active as she's still active as director of the Food Equity Council. Some of you on the call may know her from that work. And I am glad that she will still be an active member, but she no longer has to go to planning meetings. So thank you. Thank you so much, Sydney.
I have fond memories of the planning meetings.
And then one more volunteer who is changing roles but not stepping down, Sharon Zalewski, who has served as co-chair of our health equity work group, basically since the inception of that work group, as long as any of the past 4 years. Sharon recently was instrumental in revitalizing our data and assessment work group, which is working on a series of COVID disparities briefs about the root causes of COVID disparities. And she also will continue as an active member and as part of her home organization in advocating, especially for the uninsured in Prince George's County with the Regional Primary Care Coalition. So thank you all. Let's get a virtual round of applause for our staff and volunteers who keep this thing running. And now, just one more big announcement before we go to the panel. Dr. Carter and Paul, I'll turn it to you to make the big announcement here.
Okay, well, Ernie, I'll start if I may. First of all, I too want to thank Evelyn, Sydney, and Sharon for their really great work throughout their time serving on the coalition, and I was always impressed with their enthusiasm and their insights, and they made a terrific contribution. And I also want to thank you, Dr. Carter, and Allison and Donna, because you were my three musketeers and keeping me straight as far as what my role was. And as I said many times, it was a humbling experience to be a part of it. I was honored to serve, and I'm going to miss our interactions, but I also pledge to you that I have every intention of doing whatever I can going forward to support the coalition, because the work that the coalition has done and is doing and will continue to do is so very important for the healthcare system in Prince George's County. And I'm thrilled to be able to welcome Dr. Stacy Little as I pass the gavel to her as the new co-chair. Dr. Little is Vice President of Women's and Infants Health Services and Community and Population Health at the University of Maryland Medical System Capital Regional Health. That's a mouthful. It just goes to show how engaged she is in the overall healthcare delivery for our residents in Prince George's. Dr. Little is a Prince George's County native and is passionate about health equity and racial justice. And she's been an active member of the Health Equity Work Group and served as co-chair of the Health in All Policy Subcommittee. So with that, Dr. Little, I will ask that you would make your pledge to, as community co-chair of the coalition, and pleased to know that you will uphold the coalition's values, and they are to reduce health disparities by promoting health equity, to promote availability of quality health care in the county, and to engage in partnerships that can promote health and well-being in the county. And Dr. Little, are you prepared to lead those efforts?
Yes, I am excited to do so.
I knew you would be, and I'm the county's this coalition is in good hands with you. Dr. Little and I had a wonderful conversation about a month or two ago as we were talking about this transition, and transition is important, and I feel very confident that the leadership efforts of the coalition will only be enhanced by her talent and her efforts going forward. And so with that, Dr. Little, I hand the gavel to you.
Well, thank you. I have big shoes to fill, but as Paul said, I am a Prince George's County native. I have 2 children who have grown up in this county and have been educated in this county. My son has graduated from Prince George's County School, and my daughter will be doing so next year. I left this county to live in Pennsylvania and worked for a global company, and I came back to this county to work actually at a place where I started my career, which was Prince George's County Hospital. And now it has completely evolved and shifted and changed. Today we had a ribbon cutting and opened our new doors as University of Maryland Capital Region Health. And it is very exciting to be on the precipice of change in this county, to galvanize the brilliance of this county and to let that brilliance shine beyond this county, and people to know the passion and the effort and the energy and just the brilliance of people here, and how we really want to improve the overall health and wellness of our residents and absolutely change the trajectory as it relates to health equity, and one day really see real health and all policy in this county and have true examples of that. So thank you so much. I look forward to working with everyone, as I've been doing so on the Health Equity Work Group, but just everyone on the committee. So thank you again.
Virtual round of applause for our new community co-chair, Dr. Stacy Little. Big thank you to Paul. So with that, we are going to move into our main program, which is the Health and All Policies panel, Improving Health for Justice-Involved Populations. And I am happy to introduce our moderator, Guy County Department of Corrections. He's also co-chair of the Coalition's Behavioral Health Advisory Group, or BHAG. He has a background in mental health counseling and is a strong advocate for actually keeping people out of jail as much as possible. So thank you guys for your opening words and for moderating the panel today.
Wow, did you write that? That's awfully nice.
I did.
Well, good evening, everybody. The title for this is Health and All Policies. It strikes me that it really is about health and justice. I started out in working with people in corrections about 35 years ago, and primarily from the standpoint of trying to reduce crime. I thought I wanted to be a lawyer. Took a course my first semester in grad school, and I think it was called Counseling in Criminal Justice. And the doctor who was running the course basically exposed me to a whole bunch of things I didn't know about people who become incarcerated or who are in justice involved. I started working in Montgomery County 30 years ago at the pre-release center over there. And the mantra right then and there 30 years ago was reentry, getting people ready for going back on the street and trying to help them navigate and solve some of the problems that they see when they hit the street. What I learned pretty quickly is that the people that I was working with had mental health issues, had substance abuse issues, had lack of community networks, lack of skills that might make them successful in the community. And that's a tall order to try to fix, and it's a very difficult hill to get over if you're the one experiencing it. One thing I also knew about people who were incarcerated was they really didn't know how to navigate the community to get the things that you and I probably take for granted. They didn't know how to find a primary care physician. They didn't know what to do if their tooth hurt and they needed a dentist. Didn't know necessarily how to navigate social services and get hooked up with food stamps or other things that might have helped them be successful. The old saying about the chicken and the egg, which came first, it strikes me that when we look at people who are in the system, who are justice involved, you have to wonder, are the people that are incarcerated, do they have a lot of problems because they're incarcerated? Or is it people that have problems who become incarcerated? And I think to a greater degree, the latter is true. People end up being the focus of attention. They become unwanted in the community. And the easiest thing to do is move them aside, lock them up. It's traumatic to go to jail. I can't tell you the number of times I've seen people in processing who we've looked at for suicidality, concerns about their mental health, feeling like we might need to put them in a CIU unit, a crisis intervention unit in other jurisdictions. And it could be the first time, or it could be the 40th time. I was part of a substance abuse treatment group about 25, 30 years ago, in which one of our clients said, we were talking to him, and in substance abuse treatment, very often they say, do you have another run in you? Which means, do you plan to go out and use again? And this gentleman, someone asked him, you got another run in you? And he said, no, I don't. I just don't have it. And, the next time around, it's going to kill me. 6 or 8 months later, he came back through the system, and I'm talking not huge crimes. This gentleman came back on a DWI and hung himself in the jail. And I think primarily it was because we failed as a system, as a community, to figure out what this gentleman needed to solve his problems so that he didn't have to be part of a system that really isn't capable of solving problems. We've got a really good panel tonight. Ashley Sharp is working with the Reentry Task Force for the County Council. And I will tell you that a lot of very robust discussions, a lot of good work has been done there. The one thing I've pushed forth is that reentry is great, but it'd be nice to not have people enter at all. We have Cheryl Wiggum from the Health Department who's going to talk about the offender reentry program, I believe. When people get out, they're faced with a lot of problems. As I said before, substance abuse, mental health issues. I will tell you right off the jump, 31% of the people in the jail right now are on psychotropic medication. And we figure that probably 2/3 of the people have something that we could clearly diagnose them for. They just haven't raised a red flag. 85% of the people in the jail have significant substance abuse problems. They might not necessarily be on the radar for an addiction, but it's been a big part of the lifestyle that's brought them in. So it'll be good to hear about how those programs help people navigate through treatment and putting their life back together when they get out. We have Renee Enzer-Pope, who is with DSS, and she's a firm advocate for permanent supportive housing. I've been working with Renee for probably 5 or 6 years now. And the interesting thing is, we started out, she was looking to put together a grant proposal application for permanent supportive housing. And we did a crosswalk between our databases by hand, nonetheless. And out of thousands of people that we looked at, we realized we had a lot of common characters. We had a lot of common clients. People that are homeless are hugely overrepresented in the jail. Interesting things about men and women who were homeless who ended up in the criminal justice system. So she's going to talk a little bit about her perspective on permanent supportive housing and how it might assist the community, not only in keeping people healthy and out on the street, but also it economically makes sense to us. It saves money just by putting money where money needs to be spent. And finally, we have Ed Kelly, who is a registered peer recovery specialist. And Ed is a great advocate. I haven't seen Ed for a long time. It's probably been 3 or 4 years, but a huge advocate and a huge help for the health department in helping people navigate through those moments when they're coming out, when they're not sure what to do. So with that said, I think we'll start off with Ashley to talk a little bit about what's going on with the Reentry Task Force.
Awesome. Thank you so much, Guy, for that introduction. And thank you for all the work that you continue to do on behalf of the Department of Corrections. You all have been a godsend, and definitely appreciate you all leaning in as the county councilman continues to work through the different ins and outs that we've discovered with the Reentry Advisory Board. So we can just go ahead to the next slide. I'll just jump right in. So the Reentry Advisory Board was created in 2019 as a resolution, basically to identify the gaps within Prince George's County's reentry process, being able to deepen those relationships that we have from federal down to local levels, and just creating a better systemic process for pre and post release from jail and from prison. Over the time that we've been meeting, we've probably met about 7 or so times. This did come right as the pandemic had hit. So we did get to meet in person as a board a couple times, but even since then, our board has grown, and even now we're meeting each other for the first time, just because, you know, obviously social distancing guidelines have kept us apart. But it all started with this resolution. Next slide. So this is a photo from when we were convened pre-pandemic, and this is just a list of some of the, all of the organizations that have been involved with us on the Reentry Advisory Board since we've begun. As you can see, we've had everyone from the county exec's office onto our state's partners over at social services, family services, the police department, as well as representatives from our community organizations, such as nonprofits, faith-based organizations, and representatives for those who have been through the justice system. And to be honest, everybody has really brought their expertise. They've brought their just their passion for addressing this issue. You know, we constantly have a lot of those that return and go to Baltimore City. But we want to make sure that Prince George's County is best suited. You know, we take the time to identify those gaps, realign some things, and make sure that we have that opportunity for residents here that live in Prince George's County to come back home to Prince George's County. Next slide. So in the time that we've been meeting, we started out meeting as a board as a whole, but at the beginning of, I believe it was March of this year, we decided to break down into more focused subcommittees in these areas that you see listed on the screen. So we had the county provided resources, which basically includes members of the Reentry Advisory Board that are serving or representing in capacity of our county agencies. Being able to identify what we already have. I'm a fan of not reinventing the wheel. So, you know, definitely having people on board who this is their expertise, join in on this collaboration and this effort. Over time, we did end up integrating the Behavioral Health Advisory Group into this group as well. So Allison and Dr. Somerville, thank you for that. Obviously, you all have been doing a lot of work in reducing recidivism. Again, not reinventing the wheel, but having that insight for us to continue to build this report. The community engagement and service delivery, all of our nonprofits and our community advocates who want to be involved and want to be a part of the process, and honestly probably have a little bit more experience from a macro standpoint of the kinds of things that some of the gaps that exist. Sometimes you gotta take a step back to really recognize what else that needs to be done to improve our process. Resource cultivation, making this something that is sustainable. We know that Prince George's County has historically relied on state and federal grant funding, which is great to kick off programs and be able to create other opportunities. But we want to really find ways to bring this in-house and make it a priority, something that is self-driven. As long as we have all of the pieces in place, it's something that we can continue to offer as services in our county. Housing obviously is a major challenge that we face. And then obviously policy. Next slide. So this is just a little bit about the timeline. So in November 2019, the legislation was passed, CR 49, 2019. And from January to November of 2020, the RAB, Reentry Advisory Board, met on a monthly basis. March of this year, as I mentioned, we incorporated our working subcommittees, which are the areas that I just covered. And we're actually in the process of compiling our preliminary recommendations, which will ultimately be offered up to the county council. So the Prince George's Reentry Advisory Board is a temporary auxiliary group that falls below the county council. So the advisory board will not be around long term. This is not meant to be something permanent. It is meant to be, subject matter experts being able to build that report and getting to align all of those different players and stakeholders to make sure that those recommendations are lifted. So we're in the process of compiling all of our recommendations now. We've met with our subcommittees and we'll be preparing to present not only to the rest of the board, but as well as the county council, the county executive, and our chief judge in our circuit court system. This summer, July and August, we'll be presenting those preliminary recommendations to the community through community town halls. We've considered focus groups on areas that we've recognized we may not have had a subcommittee directly addressing that, but as a result, it's going to take some significant effort to just make sure all the parts are aligned. For example, transportation or mental health. Those are items that we know that we have partners on board, we have people who are interested. It's just a matter of determining those next steps to make sure that it really sticks and that this report won't just become something that sits on a desk and collects dust. And then coming September, November, they'll continue to meet on a monthly basis in preparation to take in all of those, all of the feedback that we received over the summer from the community, and we'll put them into a final report to be released by December of this year. Next slide. Oh. Okay, it may be frozen. Okay, here we go. And just to give you guys an idea, in our Reentry Advisory Board meetings, which are open to the public for viewing, these are some of the speakers that we've had previously. Obviously, we've had our Bridge Center at Adams House under the Health Department present, but we also know that we have our neighbors right over the line in the District of Columbia who have also been providing input and insight on how they run their systems. So the equivalent to the Bridge Center is the DC Ready Center. As you can see, we also have had the DC Department of Corrections come to present as well. And actually, excuse the error, the final point about the Office of Department of Labor, that's one of our next steps. Workforce development is a major area that we're going to be continuing to build out a pathway for. But we actually had the Secretary of, let's see, Guy, you might have to help me with this, the Maryland Department of Public Safety and Correctional Services, I think that's right. We had the Secretary Robinson and their staff come to speak to us as well. So we've really been doing our research. We've been, like I said, not reinventing the wheel and refocusing on what our process is and where the gaps are. I think that's it. So that's just briefly what we do. I'm definitely excited to share with this group what our preliminary recommendations look like. We would love to have you all be able to be a part of our town halls and our opportunity to have input. We really want to make this as comprehensive and macro focused as possible. Whatever legislation may be required to continue to break down those barriers or MOUs that may be helpful to make the returning process a little more smooth. We've definitely been spending a lot of time with our agency stakeholders just to make sure that we are on the same page. We know whatever the left hand knows what the right hand is doing, but just really making sure that we put forth the effort to make a sustainable and smart reentry process for Prince George's County residents. So thank you.
Thank you, Ashley. One thing just to mention, it's a, you talked about this being sort of a deadlined group, but I think one of the recommendations has been the ongoing discussion for multi-agencies across the county to talk about reentry types of issues with housing and benefits and workforce development. So just putting that out there. I'm constantly pushing for a ongoing forum. Next up, we have Dr. Cheryl Wiggum, who's going to talk to us a little bit about the offender reentry program.
Okay, good evening, everyone. I'd like to start by thanking the Healthcare Action Coalition for allowing me the opportunity to present the work of the Offender Reentry Program. The county's commitment to providing supportive services to our returning citizens so that they can pursue healthy and productive lives in our communities is invaluable to us and greatly appreciated. Since the inception, you can go to slide 2, the next slide, thank you. Since the inception of the Offender Reentry Program in 2016 as a Substance Abuse and Mental Health Services Administration SAMHSA grant-funded project, the Prince George's County Offender Reentry Program has worked to reduce recidivism among offenders who are returning to the community after a period of incarceration at the County Department of Corrections. When the SAMHSA-funded program ended in 2019, the state of Maryland recognized the success of the project in the county and provided continued funding through the Substance Abuse Outcomes Partnership, also known as STOP. The Offender Reentry Program has remained part of the county's recovery-oriented system of care in which strength-based, culturally competent decision-making is paramount. All program services are client-centered and designed to make consumers feel valued and supported as they seek to reintegrate into the community. And all services can be accessed at one centralized location, which is the Bridge Center at Adams House in Suitland, Maryland. Next slide, please. You can go to the next slide, please. Under the Offender Reentry Program, the Prince George's County Health Department collaborates with the County Department of Corrections to deliver the following services. One, in-reach, including evidence-based screening to determine the offender's level of risk for recidivism. This means that our assessments emphasize the application of the findings of the best available current research. A second deliverable is assessment that identifies the offender's risk factors for recidivism, such as prior criminal history, family marital relations, peer influence, pro-criminal attitudes or orientation, job readiness, alcohol and/or drug problems, antisocial behavior patterns, personal problems with criminogenic potential, history of perpetration, history of incarceration, barriers to release, and social and mental health issues. A third delivery is case management involving person-centered action plans that address identified risk factors using evidence-based interventions, including peer support and linkage to treatment and support services in order to reduce the potential for recidivism and relapse. Our person-centered approach means that there is focus on the individual's strengths, that we treat people with respect and dignity, and that we collaborate with the person to improve their quality of life. On this slide, I identified one of the primary assessment tools used by the offender reentry staff, which is the LSCMI, the Level of Service Case Management Inventory. The LSCMI enables our staff of clinical case managers and peer support specialists to evaluate general risk need factors, as well as specific risk need factors, institutional factors, other client issues, and special responsivity considerations such as cultural and gender-specific needs. Next slide, please. The LSCMI is an integral component of our case management planning, and a good case management plan is essential to our success in helping returning citizens navigate and overcome the challenges and obstacles they face post-release. That's why person-centered action plans, evidence-based interventions, peer support, and linkage to treatment and support services are so important in the work that we do. Next slide. In the spring of 2021, the Offender Reentry Program surveyed 81 offenders who have re-entered the community and who are currently participating or have previously participated in the program. The goal of the survey was to assess client satisfaction with program services and to solicit client recommendations for improving the program. Our sample consisted of 81 African-American male offenders formerly incarcerated in the County Department of Corrections who participated and or are continuing to participate in the offender reentry program. 90% have been incarcerated more than once, with the total average time spent behind bars being 22 months. However, the median sentence served by members of the sample was 4 months, which is more or less characteristic of the overall population of the Department of Corrections. The survey instrument used was developed by the Offender Reentry Program Evaluator, Dr. Lorene Thomas, and consisted of 15 questions that were mostly close-ended or multiple choice. And let's see, you can go to the next slide, please. From the survey, we found that majority of the sample began receiving offender reentry program case management services while still incarcerated. About 2/3 met weekly with their case manager, while about 1/3 met bi-weekly with their case manager. The overwhelming majority of those who received case management services were either satisfied or very satisfied with the services they received. They found their interactions with case managers to be instructional and motivating, helpful, and fostering good communication. The 2 respondents who were not satisfied with the case management services felt that the number of contacts they had with their case manager was insufficient, or the contacts were not consistent. All respondents who received case management while incarcerated continued to receive services once they were released. Next slide. Some men who did not receive case management while incarcerated began receiving those services upon release. As a result, the proportion of respondents who received case management at some point is 84%. Once released and in the community, 94% of the respondents expressed that they have been satisfied or very satisfied with the case management services they have received. The high satisfaction rate may be due to the fact that 75% of the respondents who received case management while incarcerated continued to meet with the same case manager once they were released. Respondents noted that the services were supportive, helpful, linked them to items that were requested, and case managers were seen as promoting good communication. The average amount of time the respondents received case management once in the community was about 4.5 months. A little less than half of the respondents reported that they always followed through with recommendations and advice given by their case manager, whereas slightly over a half reported that they sometimes followed the case manager's advice. Next slide. The original program design included transportation assistance to facilitate participant access to health and social support services once they returned to the community. The COVID-19 lockdown and social distancing mandates greatly affected the need for the availability of many of these services. Nevertheless, about 2/3 of the respondents reported that they had used the transportation services. Of those who used the services, 67% were either satisfied or very satisfied with them, qualifying them as helpful. The remainder were neutral, neither satisfied or dissatisfied. Next slide, please. When asked what service could have been most beneficial to them upon reentry, 50% replied housing. The remainder of the responses were divided equally among court intervention, parenting classes, food stamps, health insurance, and resume writing skills and or other training. You can go to the next slide. The results of the survey present an encouraging portrait of the effect of case management services on a population of reentering citizens. Despite the challenges posed by COVID-19 and several bureaucratic barriers that limited access to incarcerated offenders, the offender reentry program was able to serve 83% of offenders who were eligible for services and to deliver services to 71% of men while they were still incarcerated. The overwhelming majority of case management clients reported high levels of satisfaction with the services and credited the offender reentry program with easing their reentry into the community by providing helpful information, motivation, and support. The transportation assistance was also welcomed by 2/3 of the program's clients. The findings indicate that the overall case management and transportation assistance services met with high levels of satisfaction and appeared to achieve their stated goal, namely facilitating offenders' reentry into the community. Consequently, the recommendation is that these services should definitely be maintained and, if possible, expanded to all reentering citizens. Another recommendation relates to the respondent's suggestion for needed services and program improvements. The most commonly cited area was housing. Open-ended comments indicated that the problem lies with the lack of housing in the county in general, and not a failure on the part of the offender reentry program staff to assist clients in finding housing. And of course, many of us are aware that locating stable housing for reentering citizens is a challenge. Therefore, cross-agency efforts involving the Department of Social Services, Housing, and Family Services, respectively, are imperative in order to address this need. Next slide, please. Now, this slide recounts the Health Department reentry projects, which started in 2016 with the SAMHSA grant, to the most recent grant application, Innovation in Reentry, Building Capacity, which is pending decision by the U.S. Department of Justice. Something important to note when viewing this slide is that all of these initiatives have been or are federally or state funded. And I want to publicly recognize Dr. Jacqueline Somerville, the Health Department Public Health Program Chief, and Dr. Lorraine Thomas for their awesome work in pursuing these grants for the Health Department. However, as most of us know, and Ashley mentioned, grant funding doesn't last forever, which is why we see the grant-funded reentry projects as a springboard to the county taking ownership of its reentry projects and providing a countywide, comprehensive, high-quality, sustainable, evidence-based program for reentry services. Next slide, please. So what would this look like? First, it would be a system of countywide data collection in which the reentry program database, which is efforts to outcome, or we call it ETO, shares reentry data with the Public Health Information Network, a database which links local providers with each other and the State Health Information Exchange. This is important because many reentering citizens have significant medical and behavioral health needs and are often high utilizers of the healthcare system, which of course can result in a financial burden to the county. Second, we would use what the health department has learned through the work of the Offender Reentry Program and other reentry initiatives to train and equip reentry service providers in the community so that they can duplicate what the health department has done so successfully. I'm happy to say that this is an area the Reentry Advisory Board is pursuing under the leadership of Councilman Calvin Hawkins, and that the health department currently has a grant pending approval to fund this work. Lastly, a countywide system of comprehensive, high-quality reentry services must have stable funding. I believe Prince George's County is up to the challenge and can do this in a way that it will be a role model to other counties in the state as well as across the country. With that, thank you for your attention and your time.
Thank you, Dr. Wiggum. You mentioned housing. And I can tell everybody that we've consistently found that about 20 to 22% of the people in the jail report that they are either flat out homeless or they are at risk of being homeless and kind of couch surfing between people who will let them in the house for periods of time. Which segues right on into what Renee Anser-Pope is going to talk about. I do also want to mention before we get there that Cheryl had mentioned data sharing. As part of our permanent supportive housing initiative, we spent about a year working on a county-wide data sharing agreement. So we've got the framework in place. I think we need to flesh it out and figure actually how those things, how everybody's system talks together. But with that said, let's move on to Renee Anser-Pope to talk a little bit about what permanent supportive housing might mean to us.
Renee, I think you need to unmute.
I sure was going, wasn't I? Thank you, Allison. And you can feel free to mute me to keep on track and time if you need to. Thanks, Guy. Guy had asked me to speak a little bit about the intersection between homelessness and jail. In Prince George's, we tend to add a third leg to that stool, and that's the healthcare system, because we recognize that all three of those systems are uniquely integrated in terms of some of the individuals that our respective organizations and agencies address. So if you could go to the next slide, Allison, I'm going to talk a little bit about, and I actually borrowed this from the Urban Institute. At the end of this will be some links for those of you that are data wonky or are driven by diverse information. I gave you several links to other information sources that might be useful to you. So this is a complete pullout from an Urban Institute document, but I thought it really spoke well to the intersection of the homelessness and jail cycle, the chicken or the egg. They're deeply intertwined. Often individuals are cycling into homelessness because of their criminal history that is resulting from incarceration, or vice versa. They're cycling into incarceration because of low-level crimes that are a direct result of survival and the need to survive, like loitering, sleeping in parks, trespassing, squatting, things like that. That keep them disconnected from the necessary supports that allow them to stabilize, and then in turn reduce recidivism or criminogenic behaviors. Overrepresented in all of our systems are our BIPOC communities that are disproportionately experiencing systemic or structural racism. Just as a side note, the county's continuum of care for homelessness is partnering with 8 other jurisdictions in the Washington metropolitan region. And over the next 12 months, we'll be doing a very deep dive into racial inequities in the region and their impacts on homeless systems, as well as actual racial inequities within the homeless system in efforts to continue to improve our system. So this committee and others will certainly be getting reach outs from us as we engage in that work. But it's really critical to understand the connections between these so that we can understand the opportunities to map our systems together, to leverage our funding together, to open ourselves up to really understand what a systemic system response is to the experiences of people who may be homeless and or at risk of homelessness and overutilizing non-traditional systems like jails, like hospitals, like health systems as a default response to addressing a housing need. Next slide. So these are really just quick little pictures that I'm a very visual person, so I like to see how things look. But this is based on the urban study that people who are incarcerated are more than 13 times more likely to experiencing homeless than the general public. Oftentimes, as you well know, right, a stay in the criminal justice system often has negative connotations for applying for apartments, for getting jobs, for accessing services, even right down to the ID that you have says that you're from the Department of Corrections ID as opposed to a regular photo ID, just the connotation and the impression that the public then gets from that type of identification, and how we're not lifting up our residents necessarily in the same way we would other parts of our community. Next slide. And this speaks to the flip side of that, which is those individuals who are unsheltered increases their interaction with the criminal justice system. And you'll see the blue represents unsheltered persons and the yellow represents sheltered persons. When you're looking at police contacts, jail spells, ER visits, ambulances, all other parts of our human services system that these customers touch, and the disproportionality between those who have housing and those who do not, and the likelihood of their incarceration, or the numbers and quantity with which they experience incarceration. Next slide. And then this last one is really around cost, right? The business case for housing as a healthcare prescription, housing as a incarceration prevention. And so this really looks at, and Guy and I are working with a national organization in this space fairly deeply right now, looking at quantification of what it costs not to take action versus the quantification of cost of a housing action, and the disproportionality between the two. So the homeless jail, and I'll add hospital cycle that our clients tend to have, that our residents tend to have when they're intersecting with our systems is extremely expensive. And when you look at, this is just a 90-day case of a jail cycle in Denver of one individual who cost the community $4,000 just in that 3-month period, based on only one arrest and some additional police contacts and one jail stay. This does not include the cost of care related to any ED visits or services they might have gotten, or any homeless system shelter stays that they might have gotten. In a pullout of this, which I did not include in the presentation, but we looked at some high system utilizers that had high connectivity with the health department, the jails, and homeless services. And one of our high system utilizers in a single year represented $800,000 to the county in direct service intervention costs. And post-housing in a permanent supportive housing environment, that cost for an annual year dropped to $72,000, which is a significant business case when you're making a financial argument for alternatives to some of our more structured systems. But it requires system integration across multiple systems to do that. Next slide. So this is just a real quick definition of permanent supportive housing. Basically, it's an intervention without a designated length of stay, and it pairs housing with support services, right, to achieve housing stability. That's pretty basic. It could be site-based, could be tenant-based, could be inside the homeless system, could be for the health system, could be residential rehabilitation, could be recovery houses, could be a number of different structures to achieve this, but permanent supportive housing is in essence that. Housing plus supportive services, stabilization, long-term health and well-being. Inside the homeless system, right, that requires the person to be homeless, and it requires at least one member of the household to have a disability. It's going to prioritize those that have multiple experiences, multiple barriers to housing, and unable to maintain housing stability without some interventions. But in a general term, permanent supportive housing is just that. Next slide. So what are the benefits, right? Reduced costs. When we house people, their use of high acuity system responses are lowered. It reduces recidivism. 86% of the participants who are housed in a permanent supportive housing structure are likely to remain in housing. It improves system integration, so it maps major systems together to create a holistic response. And is client-centered, right? The idea is to stabilize the individual inside of their community in the least restrictive place possible in ways that support their long-term connections to community, their personal well-being, and their long-term housing stabilization. Next slide. And this is just an example. The left one is a comparison group of individuals who did not have a permanent supportive housing and their number of touches in a certain period of time versus a subset of individuals that got permanent housing and their touches over a period of time. The blue is healthcare services, the yellow is jail, and the black is shelter stays. And you could see the quantification of the cost related to that work. And you could see that with permanent supportive housing, all of those touches are reducing over time. Next slide. And this is just an interesting piece that I thought I'd drop in here for COVID. On the left side of that dotted line are the police interactions for people who are unsheltered and homeless, who are trapped in the homeless jail cycle before COVID hit. And you'll see thanks Megan, you'll see the blue is the number of criminal public safety touches. And when you see post COVID, you'll see that drastically reduce for the period of time. In Prince George's, we put some non-congregate shelter and some other assets into place temporarily, which has also influenced this number in Prince George's. Next slide. And then this last slide is just some sample researches. The top two are some permanent supportive housing specific case studies and clinical practices. The next two are publications from SAMHSA that dig into what the implications are from a health perspective. And the last two is both the study that I referenced here and some additional work around how counties can stand these up in a reentry environment. Thanks.
Thanks, Renee. It just never ceases to amaze me how impactful it is. Putting a roof over somebody's head changes their wellness, their entire outcome, whether they end up in jail or not, whether they're committing these minor crimes. It's amazing. Our last speaker is Ed Kelly. As I said, I've known Ed for, I don't know, since just before the Bridge Center opened up, and a huge advocate for making sure that people have the kind of network and support getting out the door. So with that said, I want to jump right in. Ed, are you ready?
Let me just log and get off mute. Can you hear me? Can you guys hear me?
We can hear you.
Yes.
How you doing, guys? I ain't seen you in a while, maybe. Well, first, let me say that a lot of my touching points have been covered throughout this presentation, but I will add that there hasn't been a program like the Offender Reentry program that I've been affiliated with. I haven't heard or seen such a thing where people are so dedicated in finding help and resources for our returning population. I was first introduced to the Prince George's County Health Department by way of a partnership between Living Classrooms, where I was working with them to participate in the Safe Neighborhood Initiative in the county. And from that work led me over to behavioral health side with the health department, actually being employed with the health department, doing the work that I'm doing. It is very important for returning citizens to have some of the things that we discussed here, housing being one of the most important things, as well as employment and health care. Being able to just get an ID, some of the simplest things are so important to individuals returning back into society. And when a person doesn't have a place to call home or address to call home, it makes even obtaining the address very difficult. I'm one of those individuals, when I have these speaking engagements, I become overwhelmed because of the progress that I've made in my own personal life. And so it brings me a lot of joy to be able to participate in someone else's success and be able to help. And I can tell you, for these years I've been with the health department working directly under Dr. Wiggum and Dr. Somerville, it's been different. I think, and it gets trying even for us to do the work when we have to sit back and think about if your program that's being funded is going to be funded again to keep you employed. But it's been working. And what I can say is I use my experience, my past, to motivate individuals with my current position. And I say, if I can do it, anybody can do it. However, I didn't face some of the challenges that a lot of guys and women face when they get released from incarceration. So I think that even though it's a lot of work still to be done, I think the work that the health department, at least the part that I'm a part of and I know about, because there's a lot of things I don't know about, is getting better as time goes on. I'm one of those people that I bring out the worst in every situation. We be sitting in the meeting and we'll be talking about how we're going to help people. And I'll bring up the negative side because I know what that looks like. And I can tell you that it'd be a struggle trying to convince Dr. Wiggum that something doesn't make sense. And she always make me see the other side to give me a different perspective. So the work that we do with the return of citizens is just giving them another look or another perspective from the other side that people really don't think about. I think it's very important to get involved with the individuals in pre-release while they're still incarcerated. It gives you kind of a jump start for when they come home. You know what I mean? You can kind of start laying out the blueprint for the things that need to happen for them once they're released. Because by the time a person gets released, if there's not no programs or there's not some certain things set in place to help solidify that person's success, they're going to recidivate. You know what I mean? In the summertime, now I might not do some foolish things because it's hot. I can sleep in the park or, you can hang out all night. But in the wintertime, it's people going to be looking for shelter. And if that means breaking in the car or sleeping in the laundry room or doing something like that just for shelter to stay warm, they're going to do it. And if you think about some of our people with mental health issues and substance abuse issues, they recidivate on a constantly basis for trespassing. Little petty things, just to be able to eat. You know what I'm saying? So I mean, I could go on and I can go to the beginning and I could talk about all the trials and tribulations that I endured myself to get to where I'm at today, holding down the job and being a small business owner that's self-sufficient, that don't even require my attention most days. But it gives me a certain kind of gratification to be able to help somebody. And when I can't help them, it kind of irritates me a little bit because I know the woes and the problems that people face on a day-to-day basis, especially if they've been incarcerated or they've experienced some type of homelessness. For most people, I have never seen a person, I've never seen a person that didn't steal or rob to either feed themselves or to supply the drug habit or to even stay in a hotel for the night. So if we can find a way to work together to kind of provide different avenues for individuals to choose as opposed to sleeping in the alley, in the car, in the laundry room, stealing from the grocery store to sell something to get high. Sometimes less is best, but with return to citizens, the more we have to offer, the more alternatives we have to offer, the better outcomes we're going to see from our men and women that's been returning from being incarcerated on the state, even federal people. We have federal people that come to the Bridge Center just because they heard that the Bridge Center is doing something special. And some of them just come just because they know I work there. So they be like, if this guy can get a job doing this, we got to go see what they're doing over there. So, I'm not special. I just try to work hand in hand with the people that I think is special, because this reentry program, this ORP and reentry support, I got to be the first to say, I never heard of no such thing. This stuff wasn't around 15 years ago. It just wasn't around. And the fact that it's a one-stop shop where you can go to, and it's a team, not one person, but a team of individuals that's trying to work on all the aspects, everything that you need. It's a bunch of people running from room to room, and office to office, and email to email, trying to figure out how you can help this one person. And I think it's a great idea. And if we can find a way to keep this program around, I think we'll have a little bit more success out here in Prince George's County. And again, you have other counties, even DC. When you talk about, I'm familiar with the DC Ready Center, but actually it's under building blocks. So they're trying to emulate something right now that Prince George's County is already doing. That's pretty much how it looks, because DC got a lot of programs, but I ain't never heard of a program like the Bridge Center at Adams House. Never heard of it. Even with C. Sosa, I just never heard of it. So I think we head in the right direction. Not sure if that's the speech you was looking for from me, but after sitting back listening, I just get kind of like these funny feelings of like, I'm really in the meeting with people trying to help other people just like me. And it just amazes me sometimes. And I'm really happy to be a servant to the Prince George's County Health Department Behavior Health Division.
I appreciate having you here, Ed. Thanks for talking with us. Several things got pointed out to me tonight, and the first one is health means having a roof over your head. Health means having an option other than going to jail to be taken care of. Health means having some support when you hit that pothole and end up in jail, or end up on the street, or end up without any kind of assistance from anyone else in the community. Ed, you spoke a little bit about that disenfranchisement, not having anyone to turn to, and I do believe that the work that you guys are doing, and the work that we're all doing with returning citizens, it offers that type of networking. We're going to open it up. I believe Ron is going to handle question and answers. Is that correct? We got a few minutes left.
Yes.
This is Dr. Carter, I'm sorry, I'm going to have to jump off because I got a 7:30 COVID panel that I have to be on, but I really would like to thank you all for an excellent panel discussion. Thank you for leading it, Guy. Of course, everybody on the panel was excellent. Really appreciate you, Ed, all of the things you said. You said your speech was right on. So it was great because it gave that touch, and I needed to hear it. I know a whole lot of people need to hear what you said. And you defined sort of the history of what we've done here with the reentry program. And Ashley, I really appreciate the work that the council's doing, and I know that you all have been pushing that envelope, trying to get the dollars we need. And of course, Renee has always been just the staunch advocate of making sure our citizens get housing. So one of my jobs is to make sure it works. And I just really appreciate you all having this. This was really great. I know everybody will join in with thanking you all for having this. And I'm sorry I have to jump off, but I did want to thank you all before I left. So, and Allison, I thank you for putting this forum together. And I will this is our coalition is I believe very strong. And so we've got to use this strength to make sure that we keep funding for the reentry. All of the things that you all we are doing in every aspect of what we're doing. So thank you Again, I hate to be, but I gotta jump on this other call. Thank you.
All right, Dr. Carter.
Thank you, sir.
You're
So,
welcome.
so I believe at this time, if we're going to ask that if any of you have anyone that has listened to the presentations this evening, if you would please place any questions that you may have in the chat, and I will direct them to the panelists for their answers. And while we're waiting on a few questions to come in, I would just like to introduce myself. My name is Ron Garrett. I'm serving as the director of the Bridge Center at Adams House. I'm still very new in this role. We started around March, and I'm excited to be a part of this dynamic team. Dr. Wiggum, Kelly, and Dr. Somerville. So awesome programs that are taking place, and we really I appreciate your support in moving forward to better serve returning citizens that are re-entering our communities.
No questions.
Our first question, conversation. No, wasn't a question. We're going to ask anyone, if you have a question or have anything further you would like to hear from the panelists, if you would, please record it in the chats and we will direct it to that panelist.
Dr. Garrett, can I just add quickly, shameless plug for the Reentry Advisory Board will actually be taking place this Friday. So for all of you who are present here and may be interested in listening in on what actually will be the preliminary recommendations from all of our subcommittees, they will be rolled out this Friday morning at 10 a.m. So happy to work with Allison or Megan on getting that registration info to you all.
The presentations this evening must have answered all of our questions. You all did such a great job. I don't see that anyone has any additional questions from our panelists this evening. Does any of the panelists have any additional comments that you would like to make?
I just thank everybody for giving me the opportunity to run my big mouth. And I saved a bunch on my Geico car insurance. You got to break up the monotony, man. You got to break it up. I'm over here fighting back tears. I got to laugh about something.
Ed, leave it up to you. I want to thank everybody for some really thorough presentations. I think there was a lot of information that was put out there and a lot for people to think about how all of these different sections come together to create wellness for an individual. So again, thanks everybody. Allison, do you have any final comments? Is there a wrap up?
Yes, so I'm going to turn it to our newly minted community co-chair, Dr. Stacy Little, to make a couple quick announcements and then close us out. Stacy.
So Allison, are you making the announcements first or am I closing out first?
We'll make the announcement first. So we have a health policy analyst position as a research assistant position with the HEAL work group. And we will put the application link in the chat. So if you know any interested candidates who want a part-time position working with us and helping to put together awesome panels like this, send them right over. And we are also looking for, we have extended the interest period for our health equity co-chair. So we will also put that link in the chat. And so over to you, Stacy, to bring us home.
I just want to thank the panelists. It was very enlightening, particularly interested in the work of, supportive housing, permanent supportive housing in Prince George's County and the impact it can have. not only on those who are reentering, but as we think about prevention, particularly for our homeless youth or transgender populations who may also be engaging in survival behavior to sustain themselves because of inability to become employed, et cetera, stigma, and those kind of disparities that fuel sometimes these kind of behavior, sometimes these acts that can get you in incarcerated situations. So I just want us to really just, as we walk away from this conversation, think about not only those who are reentering, how we prevent that, but also how we prevent people actually from becoming incarcerated, and particularly those who are super at risk in our county, and just how we might address that as we move forward. I know that someone put in the chat box that there's a meeting on Friday. So please see that if there is further interest that you have about this issue of reentry. And it's been open to us and welcomed us to participate in that. So please do take advantage of that if this is of interest for you. Again, thank you everyone for participating. I know this is a long meeting, but this was a very thoughtful meeting, and look forward to more thoughtful conversations with individuals of this committee. So as we think through how we improve the health of people in our county, we have to address these very difficult issues and think through best approaches to address them. So look forward to all of that.
Thank you. Thank you so much. Thank you to our panelists. Congratulations to Dr. Little, and have a good evening, everybody.
Hi, everybody.
Thank you. Have a great evening.
You too. Great evening, everyone. Bye-bye.